beginning of these seminars from time to time because I think they're so important. And as I look at Sarah's wonderful title here, Standing on a Burning Platform, Building a Provincial Wait Time Information System, that burning platform is a metaphor that we can use for so much of e-health. And it's so important that all of us interested in bring a passion and a sense of urgency because the needs are so huge, the value of important ideas is so great, and we must simply produce a substantial band of talent that responds to these needs in this particular opportunity. And that's what you're about here, expanding that band of talent, and we must do it with great urgency. As you look at other examples in history of important things coming along, I think we draw lessons. Let me give you one that's well known and one that's not well known. It just occurred to me, actually, as I was doing a little work last evening on something. One is the Internet. How did the Internet come about? And I've told the story many times because there's so many truths to it. The Internet is a wonderful swords into plowshares story. The Internet was really born, if there's a birth, when Sputnik went up in 1957, and the U.S. government says we have to respond. The Russians have stolen the march in outer space. We must respond from defense point of view. We must respond from the freedom of society point of view and the pride of the United States. And President Eisenhower at that time started NASA with a major effort to put later the man on the moon. But they also started DARPANET, the Defense Advanced Research Project Agency, which for purely defensive intentions created a fail-safe system of communication which would link Washington to the command centers in Colorado and Alaska and I guess somewhere up in the tundra of northern Canada, etc., so that should a bomb fall on the Capitol or one of the other links in the communication chain, there would be a spider web or a series of communication networks that would permit instructions to go back between the commander-in-chief in Washington or wherever else he or she might be and the commanders in the field. Never intended to be used, only if an atomic, later hydrogen bomb dropped. Controlled by one agency, the Department of Defense of the U.S. government, a monopoly. No use beyond that, and a single purpose. And a great deal of money was put into DARPANET for purely defensive reasons as a sword never intended to be used. And then when it was there with the installation, the Defense Department decided, well, it's an awfully good method of communication. It's totally classified and it works very well. A lot of money is spent to keep it working. Why don't we use that as the method of communicating with scientists doing classified research in universities around the United States, which was done. And then those scientists began using it to communicate with one another. And then they began using it for their non-classified research. And then the fateful thing happened. It got into the hands of their graduate students. And the game was over. Because graduate students are the most, and I've said this in this room before, the most imaginative, irrepressible, curiosity-driven, thoughtful people in the world. And that really was the birth of the Internet getting legs and being used as something other than a sword which was never intended to be unsheathed. And the other important development, and there would be 5 or 6 others, but it was Tim Berners-Lee's and colleagues at CERN in Switzerland and France, a great physics center that crosses the border, needing an e-commerce way of communicating their results and having their discussions back and forth. So he invented the language that became the prototype for what we now use today. A very, very powerful instrument that has the opportunity to do so much good in the world coming about because of important ideas and massing talent, etc. The other obscure example is I was at McGill for 20 years, and during that time, Dick Cruz, our retired Dean of Medicine, with another wonderful McGill graduate retired, did the 19th century history of medicine at McGill, and it's a glorious story. McGill was essentially founded by 4 University of Edinburgh doctors in 1819. I won't go into the story of James McGill's will, but they actually had a sit-in at the university before the doors of the university were opened because the will was disputed. And it was these Edinburgh doctors that got it going. In Edinburgh, the reason McGill and Bishops and Queen's University have principals as opposed to presidents or rectors is they're Scottish universities. And the influence of Edinburgh was very strong on McGill and Queen's and Bishops in those early days. And for years and years after, the bright young men, they were only young men in those days, it wasn't women until about 1885 in medicine, would go off, the brightest of them would go back to Edinburgh, would go to Edinburgh for their graduate work, and then they'd come back and become professors of medicine or surgery at McGill. I was there a week ago, and I went by the Roddick Gates, the main entrance, and I never fail to have a shiver up and down my spine when I go by the Roddick Gates, and the ghosts of McGill's past to speak. I listen to them. They have very wise advice. Because Roddick was a young Newfoundlander. Newfoundland was not part of Canada. And he came to study surgery at McGill with one of those first professors of medicine. And then, being the bright young man, went off to Edinburgh to do postgraduate work and then came back and taught. And he was a clinical professor of surgery. And he had his small operating room in the Montreal General Hospital down in Old Montreal. And the two great men had the operating rooms beside him. And we're now about 1875. And Roddick had studied under the great Edinburgh physician, whose name just slips my mind, but he used carbolic acid in the operating room. In fact, he lost the use of his hands because the acid was so strong. But he did so because he knew that infection in the operating room did great damage. And his young student came back to McGill and began to spray his operating room with carbolic acid. The two older surgeons almost threw him out of the hospital. Thanks to the intervention of a then relatively unknown, this would be about 1868 to 1870, because this individual was still relatively unknown, by the name of Osler, intervened and says, you can't stop him operating. A, he's not doing any harm. B, he might be doing something very useful in that operating room with carbolic acid. A couple years later, the dean of medicine and the chief physician and surgeon of the hospital was presented with the statistics from the 3 operating rooms in the Montreal General Hospital for a 2-year period. The mortality rates of the 2 senior docs were between 45 and 55% after their surgeries, and almost invariably because of post-surgery infection. And in the case of young Roddick, it was less than 5%. And this went on for 1 more year. And the good Dr. Osler intervened a little bit further and said to the dean, something's going on here with carbolic acids, with a 50% mortality rate in 2 and a 5% in the other. Not only can you not kick Roddick out of his operating room, but you've got to instruct those senior gents that they have to begin using carbolic acid in their operating room. And they began to do so, and their operating rates fell down to 5% or so. Osler then went off to University of Pennsylvania, and then to Hopkins, and then to Oxford, where he held the Regis Professorship of Medicine. Died in 1919 of a broken heart. His son, his only son, was killed. Only child was killed in World War I. But during that period of time, he was writing the Principles and Practices of Medicine, which, when it stopped publishing, about 1960 or so, had gone through, I think, 43 different editions, Canada's most famous doctor. But I give you that story, the internet story, which is well known, the swords and the plowshares, and this carbolic acid story, which is less well known, to say that, you know, we do stand on a burning platform. And it's very important that we amass the talent behind these powerful ideas, because modern information technology can make such an extraordinary difference in the quality of health care and the promotion of good health in our society. And you happy band of warriors in this room have a very special charge to make it happen. Thank you.
Well, thank you, David, for your most interesting introduction to this series. I welcome everyone today. I'm Shirley Fenton, Managing Director of the Waterloo Institute for Health Informatics Research. And I thank you for joining us today as we kick off our new seminar series on e-health strategies. We also welcome those of you who are joining us via our webcast. And just to let you know, we had a little bit of a panic of those of you that are joining the webcast that we might not be able to get to you. So we're quite delighted that everything is working now. Special welcome to our speaker, Sarah Kramer, VP and CIO of Cancer Care Ontario. And a special thank you to our seminar series sponsors, McKesson, VON Canada, Healthcare Information Management and Communications Canada, and Smart Systems for Health Agency. Those of you that have been listening already, we did announce that we are holding a second occurrence of our boot camp that was Our first occurrence was this summer. Very successful. 80 happy troopers graduated from the boot camp, and we'd like to hold it again, or will be holding it again, in probably March or April of 2006 in Toronto. If you're interested in registering, go to our website, hi.uwaterloo.ca. Second, the next seminar of this series is Wednesday, October the 26th, and Diane Beattie, VP and CIO of the London Hospitals, will be talking to us about their shared digital diagnostic imaging project. So that will be a very interesting seminar as well. David has very well introduced our seminar series to you. I have just a couple of comments to make about it myself, and I know we're anxious to hear Sarah, so I won't spend a lot of time. But this series is to examine in some detail Canadian and Ontario e-health strategies. As you know, massive federal and provincial investments are being made in these systems, and this series will allow us to look at these initiatives, learn what they're about, give us an opportunity to understand them better, and to critically evaluate their progress. Will these series be able to deliver what they promised? So maybe at the end we'll be able to answer that question a little bit better. We've invited key experts involved in developing these strategies, and they've accepted our invitation, so I'm quite excited about them coming. We're very pleased to host this series, and very especially pleased that Sarah's going to kick this series off. Sarah's going to speak for about 45 minutes, and that will be followed by a facilitated discussion. So I invite you to ask questions at that time. We'll try to get the mic to you so that you can have your question recorded. So please wait while Dominic and I run around trying to get the mic to you. And I invite those coming in through the webcast to send their questions in to us as well, and we'll try to work those in too. So without any further ado, I'll introduce to you Dominic Covey. Dominic is the founding director of the Waterloo Institute for Health Informatics Research, and he'll introduce our speaker.
So I won't say very much because we've already held Sarah up quite a bit. I thank the guys doing the webcast for the incredible effort they made. With half our network down, they somehow managed to get us together in time to actually make this work. So thank you guys for running around, and welcome to the people both here and outside. I've only known Sarah about a year now. I first heard her speak at the hospital's eHealth Council and was quite impressed with what she had to say. Also very impressed with the challenge that she faced in bringing out rolling out the Ontario waitlist information system. In addition, as we went through the year, we learned that there were significant issues related to what's called the Enterprise Master Patient Index part of that, and only recently has that been resolved. Sarah, through this entire time, what I was impressed by beyond the fact of what she was handling was she remained relatively calm. So you already know that she's the Vice President and CIO at the Cancer Care of Ontario. Her work with Alan Hudson, who's a get-it-done kind of guy, has got to be one of the most challenging positions in this province, if not the country. Alan's work here is well known. And what's interesting, I want to learn this beforehand, was that Sarah was the CIO at the Department of Health in Nova Scotia. So she comes also with good Eastern credentials and has held a number of positions in Ontario's both healthcare, government, and private sectors. So Sarah, we welcome you. You have your full time available. Don't let the time constraints worry you at all, and look forward to talking to you at the end.
Thank you very much. Thank you very much for inviting me to speak. I don't often get out of the corridors at University Avenue, so it's nice to come out and see what you're doing out here, and had a lovely morning speaking with some of the experts here, and I'm going to hopefully take some of that back and make sure that we incorporate some of that into what we're doing. I have two roles. I am the VP and CIO at Cancer Care Ontario and have kind of a full suite of responsibilities there. And I have in the last September, October, taken on this second role as essentially CIO for the Wait Times project, which is a project in and of itself that has an information component. So I'm going to speak a little bit about that project and what it's intended to do. And then in discussions with Dominic and and the group here, I thought I'd just share my early experiences and early understandings about why this project is a little different than some of the other province-wide e-health efforts, and why I think that's a good thing or not, and would love to hear questions and comments and input from you, because we're still in the middle of it, as opposed to what my boss, Alan Hudson, says he thinks it's done. He keeps saying, well, look, we're done. We'll just worry now about January '07 when this is over. And I keep reminding him we actually haven't got anything on the ground yet, and I have a fair bit of work to do. So would love to hear some feedback from you on what we're doing and how we're doing. So why and what exactly are we doing? Well, like most things in healthcare, most of you are here because healthcare basically is an information business when you break it down. And wait times is an information problem when you really think about what the set of issues are. The system, the individuals, patients, and surgeons are now effectively working blind. They aren't able to see what they're doing with respect to access, and that's an information problem requiring an information solution. The project as a whole, as I said, is led by Dr. Hudson, and I won't go into a great deal of detail about that. I will refer to it tangentially throughout. But it is a broader project meant to bring wait times down. It's not a wait times report-producing project, although that is a side effort. The point of it, the Premier's direction, is to bring wait times down in these 5 areas. So that's what we're attempting to do, and this is the curve that we hope to see over the course of the next, well, by December '06. It has a firm end date, the project itself. We hope to see that course correction by that time. What is the focus of this? A wait is not a wait is not a wait. It's not as simple as the general public might imagine. There are different types of waits for different types of service. This project really has scoped to one set of waits. There's the wait, well, there's more than this, but even in its simplest effort, there is the wait to see, in the case of surgery, there's a wait to see a surgeon. We're not measuring that. We're not monitoring that. Alan is not on the hook to reduce that. So that's out. There's a wait once, in the case of surgery, there's a wait once you've seen a surgeon, you both decided, you and the patient decided that you need a treatment. There's a wait between that point and the time that you receive that treatment. That is the focus of the wait. The same is true when a radiologist receives your family doc's or your specialist's request for an MRI CT and the time that MRI CT is received. That's the time focus. It's also not, there's another wait, obviously, to get out at the other end. And there are waits in the middle that I'll talk a little bit about. There are waits that have to do with, in the case of cancer, other treatments that you might have to seek in advance of actually getting the surgery. Or, in the case of most issues, getting diagnostic tests and other things done prior to that. So that's, I won't speak a lot to that. It complicates the data model, but that is basically the wait that we're looking at. And in terms of the clinical area of focus, it's the 5 areas that the first ministers agreed to last fall. So it's a politically driven process, politically driven and therefore citizen-driven process to pick those top 5. That's how those top 5 were picked. We didn't get a bunch of doctors in a room to decide on these things. They probably wouldn't have decided these things. Probably the people in this group would not have decided these 5, but that's what we are dealing with. They are MRI, CT, as I said, cancer surgery, not the full spectrum of cancer services, cardiac surgery, cataract surgery, hip and knee, total joint replacement. And that's the scope. What is the information problem? Some of this is well known, some of it's not so well known. And this first point, I think, is the first couple of points are not so well known. Surgeons right now, with the best of their clinical experience, the best of their knowledge, and the best of their, the most commitment they can bring to this, maintain their own patients' lists, sometimes in their head, sometimes manually, and occasionally electronically. But it's a very ad hoc process, and they themselves are not able to see who is waiting, how long they're waiting, and some sense, they prioritize in their heads, but some sense of relative prioritization is very difficult to do if you're looking at a list on a piece of paper. So they are working blind. They don't know what their colleagues are dealing with either on the other side. Hospitals and the surgical chiefs who are now on the hook as part of the Wait Times Project to know what's going on from an access perspective and to manage it down have no way of understanding how long people have waited. Particularly in this province, and it differs in some respects from other provinces. In Saskatchewan, for example, when a surgeon decides to treat, they book the OR right away, at the point of time that they make the decision to treat. So the hospital is aware of that first point in time, and they know how many people are waiting and when they should be coming up the queue. In Ontario, in most cases, the surgeons are allocated blocks of time. They manage their own blocks of time in their own offices until sometimes like a week or two before the surgery actually happens. That's when they let the hospital know through the OR booking system if there is one, and that's the only point in time that the hospital is aware of it. So the hospitals don't really know. They're on the hook to manage it. They don't know what it is they're managing. They don't know how many people are waiting. They don't know the relative priority that they need to be looking at in terms of these patients. So they're also allocating these OR times based on nothing, sometimes based on best guess on who needs more time, sometimes based on political issues, although I know that never happens here. Sometimes seniority. It's not evidence-based, it's not information-based, and nobody thinks that that's the right way to be. It's a real challenge to change that. The first way to change that is to get some information out about what is actually happening and what potentially is best practice. The province and eventually the LHINs, to be determined how much and in what way, allocate their resources in terms of these 5 areas and with respect to the access questions, basically blind. And they'll be the first ones to tell you this. They're doing the best job they can with the information they have. They don't know who has the right amount of resources for a particular area, who's got longer waits or shorter waits, and that makes it very difficult for them to answer their political masters when they're asked the question about what we're doing about this thing. They don't know what this thing is. Patients and primary caregivers, and this is an area of some dispute. Everybody has a different view on this, but certainly when you hear the politicians talk and they're talking about the questions that they get at the barbecues and at the doors, they're saying patients and primary caregivers don't have any information about where they might go to seek care from an access perspective. Now, I often hear when I talk about this, and when Dr. Hudson, who is leading this effort on the part of the province, talks about this, that patients don't want that information. They don't know what to do with that information. They look to their primary caregivers to give back to them. I think that's a matter of dispute. Regardless, it's what they think they want. So it is what we want to be able to produce. And we'll see, and it's an experiment, we'll see what effect that has. And the public considers this the most important health issue of the day. We may or may not agree with that. The general public is extremely clear on this point. And they are unable to see, the government is unable to show how the healthcare system is doing. It is the barometer of the healthcare system for them, and there needs to be some way, some sort of measured, responsible way to be able to show how the province is doing on this. So we looked early on at a detailed level. This is a very high-level view of what do we know now, what do we have now, particularly in these 5 areas. I'm not going to go into a great level of detail. I think the main graphic is it's very white. There's not a lot of black filled in here, or blue as the case may be, except in the case of cardiac surgery. Now, cancer care actually has quite decent information on radiation wait times and not bad information on systemic therapy wait times, but before we started doing some interim work in January, not great information on surgical wait times, deduced information and old information, but not helpful information for managing the system. Cardiac surgery is the standout here. Cardiac surgery has Cardiac Care Network, which functionally is an international leader. Technologically is still working at 1991 levels. So they have real issues from a technology perspective, but they're kind of out there as the sort of gold example, the premier example of what you want to do with understanding what's going on. So we're using that and leveraging that and working very closely with CCN on that. Hips and Knees had an organization called OJRR, which was not mandatory and research-oriented. So they had some information, but they had a lot of gaps in their information and the ability to access that information on the part of the hospitals, the surgeons, and patients that really thwarted its ability to help on the broader set of questions. Cataracts, almost nothing. There are a couple of research institutes, but not anything substantive and systematic. And MRI-CT, I think I was saying earlier, there's really a dearth. Even the ISIS report, there was an ISIS report that was done last spring using what administrative databases there are and kind of making some assumptions about what weights might be, was unable to say almost anything about MRI-CT. It is kind of the worst case scenario. So what are we doing in terms of an information system? Well, we're building a system, a province-wide system, that collects real-time or almost real-time, I hate to use the word real-time, near real-time information in order to publicly report wait times and in order to give those managers service providers, administrators, funders, the information, and the public in many respects, the information they need to better do their jobs and manage the system. So it's got those two functions. Depending on who I'm speaking to or who Dr. Hudson is speaking to, I switch those around, but they're both critical. The premier really cares about that first one, and people within the system, care, sort of advocates and surgeons and others really care about that second one. So it will do both. The initial focus, as I said, will be to collect real-time data, and the focus is on waitlist management within the hospital. It's not on scheduling. So all of the things that I'm talking about now, there will be tools to prioritize patients. These are decision support tools. They don't go right into the scheduling system and circumvent the surgeon's decision-making or the radiologist's decision-making capacity to override whatever prioritization scheme comes up. Scheduling is separate. The hospitals are responsible for how they schedule, and that's how that works. Referral management, referral into the hospital, I talked about in terms of the wait. That's not part of the system. It's a very complicated and important part, and we've been talking about it as potentially what we might do next, because for hospitals, when I talk to hospital administrators, CIOs, CEOs, that's a really important issue, to be able to figure out how to get patients in, get the right information when they come in, and know how long they're waiting. That's not part of the scope of this, but it certainly is an important function. So what are we doing? The waitlist management is focusing on getting information to the hospitals and the care providers that tell them who is waiting for how long at an appropriate level of identification based on access rights, how long people have been waiting when they're close to whatever the target time frame is, so that it's an alert system as well, and that's what that last point is. And from that, there will be standard reports produced on the website that will be able to, where people will be able to see by hospital, not by surgeon, what the waits are for each of those clinical areas against target time frames. So I won't go through this. This is our, started off simple, but it never ends up simple, these diagrams. A diagrammatic view of the technology. Now this is not at the technology level. This is a sort of conceptual view, but essentially, I wish I had a pointer here. Because the point in time where the wait starts and is sort of held happens in the surgeon's office, the system has to get into the surgeon's office. It can't get all the information from the hospital system because the hospital system doesn't know about a wait until, as I said, a couple weeks before. In the case of hip and knee, sometimes it's a year or longer wait, and so that's not feasible. So the system will be a front-end web-based into the surgeon's office. We'll have some information that is populated from an EMPI, which is a client registry that brings in some basic demographic information, has some physician information, some facility information, the procedure, and then a tool that gets to that prioritization, and I'll speak to that in a minute. So a wait for, typically we used to use the word elective, urgent, emergent. Nobody seems to want to use that word anymore because it implies something that is not meant to be implied. But there are priority 1, priority 2, priority 3, and weights are attached differently to those things. So that helps the physician know how he should be able to be managing his patient load, and helps the hospital understand where they should be putting their resources relative to the need. So that goes into a single provincial wait time system. When that OR actually happens, when the surgery actually happens, the procedure date will be extracted from the OR system. So you have those 2 points in time. One from the surgeon's office is the start time. One from the OR system, that's the end point. The two are calculated. This makes it sound more simple than it is. And that information goes back to all of the information users in this cycle, and those are the red areas. So the hospitals are able to understand what's happening locally. They also will get alerts about whether or not a particular patient, when a patient is booked, whether the surgeon has done his job or her job in getting them into the wait time system in the first place, because that's the main lever that a hospital has to make sure its surgeons play in this game. Access to the OR. It's an important lever. So if they don't know whether a surgeon's done it, they don't have that lever to play. That's going to be critical for them. It then will drive information out on a reporting basis to the CEOs of the hospitals, the LINs, the province, et cetera. So that's kind of performance metric information as opposed to management information. And obviously the public website. So the clinical assessment, these are the targets that people are so keen about, that the first ministers have made a commitment to provide by the end of this calendar year. Clinical assessment tools will drive these. These clinical assessment tools have been developed by clinicians, not by me or my team, who are specialists in the individual fields. They are based on the work that has been done elsewhere. So the Western Canada Waitlist Project has done a lot of work in this regard. Cardiac Care Network, this is their business. They've been doing it for over 10 years. They're well in hand. ISIS has done some work in this area. The Canadian Medical Association Wait Time Alliance has produced a public report. This is a hot topic right now, you may have noticed. So there's a lot of work to build from, but we've started at a fairly simple level. We're making some recommendations from that to the Premier, and it's really the Premier and the Minister's decision on where that goes. But we're working with a set of working assumptions, and we expect to hear a finalization of what those targets should be for Ontario sometime this fall, later this fall. So that's the what. There's more to it. I'm happy to answer questions. I wanted to talk a little bit about the how and how this differs. And this is the burning platform piece. I like this picture better than the first one because it makes it look like I have some things under control as opposed to my feet burning. It's also the right gender. But this is the part that when I was thinking about doing this presentation and thinking about why is this different and is that a good thing or not, so I would really like to hear some feedback on this. For many reasons, and I think everyone in this room knows that Ontario has a reputation nationally. I can tell you when I was in Nova Scotia, it was pretty clear, of moving slowly and in an unsystematic manner on the e-health agenda. All kinds of reasons for it. Some of those are just myth, and some of them are reality. They aren't individually, personally based. They have to do with the system being fairly disaggregated, with the size of the province, with the type of decision-making that happens. But it is what it is, and this is a real problem for us all moving forward. And implementing a single province-wide system in a province this size in 2 years, both allowed for, because there was a pressure to do this in 2 years, it's the Premier's objective, and the Premier, as I think I said to you, has a meeting with Alan Hudson every month and asks about progress. So that's something that I don't think any other e-health or any IT, unless they're in trouble, enjoy. And I hope not to be on the in trouble part. So I will talk a little bit about that and how that we're leveraging that to actually make it work for us. And it's also required. We need to take a different approach if we need to do this in 2 years. It's just not going to work. Even if everything had gone well on the e-health agenda and things were moving smoothly, 2 years to implement in 70 hospitals anything that's standard is a huge issue. So how do you build a system on a burning platform without getting burnt? So in my thinking about this, and I'll walk through some of these in more detail, but at a high level, the number one differentiator, as I said, is this political focus and commitment. This is something that the Premier will move his own systems to get done. So a lot of the discussion and a lot of the risk aversion that happens inside government is that results in 75 management board submissions to spend $5. You can understand how that happens when there's, integrated justice and gun registry and all kinds of things that have not gone well. There's a huge risk aversion. So that we're able to move out because the province risk the Premier's risk that he's trying to avert is not getting elected next time, and he considers this to be key. So he is moving a fair bit through. The minister is, and the deputy is, and we enjoy a lot of favor at that table so long as we keep producing. The leadership approach is a little bit different, and I'll talk a little bit more about that in a minute. We have a managed scope. There's always scope creep, especially if any of you do know my boss in this project, Alan Hudson. There's always new fun things, and I've already done this, so why can't I just move on to something else? But we've also taken a bit of an opportunistic approach and built out in terms of the Enterprise Master Patient Index. So I'll talk a bit about that as well in more detail. We are building on experience, and this is something that I can tell you, this is so bad, I'm bashing Ontario, pretending I still live in Nova Scotia, but this does not require a made-in-Ontario approach. This is something for wait times. Well, CCN has already done it functionally, and it needs to be improved, but it is out there. We do have a pretty good model. Saskatchewan took that and expanded it. BC and Alberta had different types of systems, but they're actually a bit ahead of us in terms of revamping them to Saskatchewan's kind of model, we don't have to do this again. We are working very closely with all those other provinces and with the CCN to make sure we know all that they know and we apply it appropriately here. The same is true for the Enterprise Master Patient Index. We're the 7th province to go this route. So we are big, we are disaggregated, but it's not rocket science to move us forward. We don't have to create everything ourselves, and that saves us some time and some sort of political consternation, small p political consternation. Accountability structures. I will talk a bit more about this, and something I didn't talk about in the general project. Dr. Hudson's project also includes, actually one of the main foci is to buy additional volumes of cases in those 5 areas and then hold hospitals accountable for delivering on those additional cases. So that's pushing more supply through the system as one way to manage the wait times down. Attached to all of those dollars for those cases, first you have to do the cases. Second, you have to produce information. You don't get the money, you don't produce the information, you don't get the money the next time, and in fact, he's pretty clear we'll claw back. And he's waiting, actually. He can't wait for the first hospital not to be compliant so there can be a test case. But he's been pretty clear. All of you who know him know that's funny. But there is a very strong accountability structure. It's also very clear that this is the hospital's accountability. So when we get back, we have an interim reporting structure, which I won't go into detail because it's just to get some information in a bit of an ad hoc way. When hospitals say, well, we can't do it because the surgeons won't do it, like, that's your problem. You talk to your surgeons. You have access to the OR as your lever. Use it. So there is support to do that, but the accountability structure for delivering on this at the hospital level has been clearly articulated, not by me, by Alan, and I'm just piggybacking off that from an information system. I have to say that is probably the number one differentiator between us and the other provinces. When we went out to BC and Saskatchewan, they were very, very envious of this because it's very hard to get uptake of something that no one is going to pay for, cares about, means anything. When it's attached to something that's very meaningful, things happen, and that's a really important difference. And the other thing is I'm working very hard to align with the e-health strategy, the local health integration network strategy, and the information management strategy. Now, I'm aligning with them. I'm not waiting for them to finish all their work before we go out the door because I have a couple of bosses who aren't that patient, and I also have this December 2006 deadline that I have to meet. So we've been really clear and had really good relationships, particularly with eHealth and with Stany Brown, who's leading the IM effort, because there's some overlap here. That's fine. We're out the door. We're moving, but we're keeping everybody mutually understanding of what's going on so that we're not too far out of line. But we're not waiting. So this is really just kind of an example of what the broader project is. Started in September 2004, led by Dr. Hudson, outside of government. Intentional decision. Alan reports to the health results team, the ADM, responsible for that, but he's clearly seen and is someone who isn't really in the government mold. We are looking at building that information system for those 5 areas, and then beyond that, we're not sure where that goes. That's something to be determined by the government. What does that mean, though, the issue of having the Premier, the Minister, and the Deputy worry about this regularly? It means that I get very fast decision cycles, and that is critical. We talked earlier about some problems in some other big systems. Some problems as they're being rolled out relate to the fact that they are solutions to issues that were identified 10 years ago, but it took 10 years to get through the decision-making cycle. So now they're a solution that might not have been a bad idea, but actually doesn't mean anything in the real world. We're really able to circumvent that, and it's fairly risky from the decision-making side because the reason they put those things into place is to avoid risk. But it is the right thing to do from an information system perspective. There is a clear purpose, and I think when we talk to some of the other people on the health results team, the other components, that's the LINS and the, for those of you who don't know, the LINS and the information management projects, our purpose is really clear and specific. We have a scope, we have 5 areas, we have a direction. From that perspective, it's easier, it's clear, we have an end point. That's not true for all projects. It's not true for all of what we try to do. It's not true for all of what eHealth is trying to do and needs to do. So that really helps. And now this is a point of dispute, and it's up for discussion. I argue that the speed actually helps us. The fact that we have to do a ridiculous amount of work in 2 years means that we do anything. If we had 5 years to do this, and people often say, wouldn't it be great if we had 5 years, we could really think about it, we could really get everything right. My own view and experience, having worked in government for a long time, is we would go nowhere. It wouldn't be anywhere in 5 years. The speed really is part of the impetus to get anything going. So that's my theory. We'll see how it plays out. So this is a Dilbert that I pulled out a long time ago when I was working in government and started in information management. And this is the cycle of decision making. It's called the informationless cycle. Dilbert comes and says, you need to give me a decision. He's asked for more information. He says, you need to give me some funding to do a study for more information. He says, you need to give me a business case to get the funding to do more study for information. You need to relieve me of all my other duties so I can work on the funding request for the study for more information. You need to give me everything to infinity, because it's never ending. So you can do these cycles over and over again, and these are the things that Roger Gerard and all those guys face all the time. Every time they move forward, they're asked to go back and get some more and go back again. This is draining, time-consuming, and very difficult to manage. So this is something I don't have to do, which is nice. I had to do it for a long time. I don't have to do it anymore. So in terms of leadership, it's a bit of a different leadership approach. Like Alan, I don't work for government directly. I actually don't even have a formal secondment agreement or anything. I work for Cancer Care Ontario, which has, I think, the beauty of being not in government but not in a hospital. We're sort of in the middle. So I don't have a vested interest from the perspective of being held to account directly to deliver a certain set of volumes. I also am not seen as someone who is part of the whole government scheme, and I'm able to get a few things done more quickly. So that really helps. Now, having said that, I'm responsible to make decisions, and that's quite clear. I make recommendations to Alan, and we make those decisions together. And we've had really next to no political interference. In cases where there could have easily been, like where to go for the first 5 hospitals, typically you need to make sure you cover, having been in government, you need to make sure you cover certain people's constituencies. You need to make sure that, there's lots of stuff that happens in those decision-making cycles that we just didn't have to deal with, and we've really enjoyed that benefit. And I really respect the political process for giving us that freedom, because that's not usual and it's not easy for them to do. We also have to we talk to a lot of people. I sit on a lot of committees. In order to make sure that I get good feedback. And I don't just sit on the committees. I think there's some people who sit on some of those committees with me. We actually present information and get really strong feedback, and we incorporate it. Now, we get lots of information, and sometimes it's conflicting, and then we decide the way to go. So we don't go back and try to get consensus. This is trying to get as much feedback and input as possible from experts, and then we make a decision and we go forward. So that's a little bit different. Sometimes if you try to seek consensus, you never actually get out the door. We have caused a few ripples here and there, and we're kind of willing to take the heat on them if they're the right things to do, and we check with a lot of people before we determine that they're the right things to do. We do them anyway, even if not everybody is happy. So there are a lot of reference groups. The OHA has a reference group that Murray Martin from Hamilton chairs. That's incredibly helpful to us. The OMA has a reference group that they've just gotten started. I kind of wish they'd gotten started a little earlier, because this is so critical to us. That is a really helpful group. I have an information management expert panel. Glenn sits on it. There's about, 12 or 14 people on that, largely CIOs from hospitals. We have CIHI on there, so we get some informatics expertise. We have ISIS on there. And we have 2 CEOs and a chief of staff. So it is IM focused, but it's also trying to get at how the system will actually be used from a technology perspective. And that is an immensely helpful group to me. They meet every 6 weeks and really I sort of throw things out and they give me feedback. It's very helpful. So there is a single point of accountability, and that's me, but there is a lot of talk to a lot of others. So some days when it's not feeling that good, it feels a little bit like this. Alan keeps talking about, he always shows this diagram and talks about it like it's a great thing. Sarah Kramer's doing this, Sarah Kramer's doing that, and all I'm thinking is this picture when he does that. Anyway, some days are better than others. So accountability. I talked a little bit about how we're aligning the information system with those funded volumes, how those dollars, there are contracts that the CEOs and the chiefs of staff have to sign when they accept the money to do these extra cancer surgery procedures, cataract surgeries, et cetera. And they have schedules attached to them. Some people here have signed them. I think, did you end up having to sign one? Yeah. That say you have to participate in this information system. So we're only going out, in terms of our scope, to those hospitals that are on the hook for those other things. I don't want to go out on my own on this. I don't want to, this has to be a wait times strategy that has an information system that supports it, in my mind. It can't be an information system that maybe we use for wait times later. So we're really focusing on that. The first 5 hospitals, we chose using criteria, fairly subjective criteria. We got a lot of feedback on what we should do. In the end, we ended up taking a lot into consideration, but primarily speed and ability to work as a team, because to get 5 installations for this system out by March is a huge, actually ridiculous effort, my developers tell me sometimes. And so we have 5 very strong people from a CIO perspective, a clinical perspective, and a CEO perspective. UHN is one of them, Hamilton Health Sciences, Grey Bruce, Southlake, and of course Grand River. So I'm working really closely with Glenn and with the people here to roll that out here. The phase 1 is what we're going to be doing by March. We have a phase 2, that was kind of our objective by December 06, is to get at 80% of those funded cases. So that's about 50-ish hospitals, and we're just sorting out which those are and the order that they get rolled out. We have a commitment to do the other 20 or so that are part of the wait time strategy. We do not have a commitment to get to everyone. That's to be determined. From a wait times perspective, it's probably not that important to get to all of them if we're looking at sort of added value for an information system to help manage surgery, because you're talking about hospitals at that point that are pretty small and don't have a lot of volume and aren't really prioritizing within the 3 or 4 that they see. That's post-December 07, and we'll see what happens there. So in terms of scope, this was a big issue for several months in the winter and spring of this year. The client registry, I'm hoping many of you know what it is because I hate explaining it. It's very complicated to explain. In fact, it's complicated to explain because it's so obvious to so many people. It's like explaining what "the" means. People assume it's there and it's needed, but it's very hard to actually define. An EMP, so client registry is a patient matching linking effort that is needed, really acknowledged by everyone, even Dominic, I think, as required for an e-health agenda to work. So Ontario does not have one. And as I said, we are the 7th province to go out. Not all 6 other provinces have it, but they're well in development. And we really need one acknowledged by everyone to move anything forward. The EMPI is really needed for the wait times information system. I told you before that we have 2 points of collection, the surgeon's office and the OR. When we talk to other provinces, and we know ourselves, it's very hard to match those things to get those 2 points in time and to do the math to get a wait time if you don't have a way to know that the way that that person is described in the surgeon's office is the same way that they're described in the OR. And they're often not, because don't forget, they don't have to register in the hospital before they show up in the surgeon's office. So that's really critical. We also really, and this again we learned primarily from BC and their testing of their new application, the surgeons, as we all know, don't want to do any more work than they have to do. They're already not going to be happy about doing extra work or having their secretaries do extra work. So we want to have accurate and easy kind of input of that patient demographic data. So that will just be populated by the EMPI. And one key issue is to track patients who are on more than one wait list. Not to necessarily not allow that, but to at least acknowledge that that happens. And in terms of the general overall performance reports, be able to kind of take out some of those waits. Some of the really long waits at the end, if you look at a tail for a wait, you look at some of those really long waits. Some of them are people who are on 2 lists, got their service in this part of the tail, but just were never taken off that other list. So we need to make sure that that's managed. And those all are helped enormously by an EMPI. We talked a little bit about the importance of it. This is probably an old diagram I took from Roger Gerard, who's the head of the eHealth office, one of his older presentations. But lots of ways to look at what an EHR may or may not be. They all have a client registry in the picture. It's needed for what you need to do within a cancer system, so I know it from a CCO perspective, from a LIN perspective. Anything you want to do, you really need to be able to link in against your patient's information. So the decision was taken, and we took it to many places and got a decision from the deputy at the end of June that we would leverage the urgency, focus, and requirements of the wait time strategy to implement the provincial EMPI. So what are we doing? Well, we're delivering a scalable client registry through the WTIS project structure. So that's that structure, that high-level structure that you saw with me at the lead, to support the wait time strategy. It will show the value of a client registry because it's sort of ephemeral right now. People don't really understand at all levels what it will do and what it can do. It will meet the urgent requirements of other key eHealth efforts, and many of you know what those are. I spoke to a couple of them. It does support province-wide standardization of technology. One of the issues with not having a really strong view of where the province is going on eHealth, one of the problems with that is people locally who are trying to get some strength and do things go on their own. They have to. They want to move forward. They need to move forward. Well, if you ever get to that provincial system and people have moved off in this direction, you're in trouble. You're spending a lot more money than you need to. So this will be able to pull in the reins a little bit in an area that's not completely, but fairly green field now in Ontario. There are a couple of exceptions to that. And it will strategically accelerate the eHealth agenda. Now, one thing I have to say, the EMPI is not PACS. It's not wait times. It's not something you can cut a ribbon on. PACS is the easiest thing in the world to sell to a politician because they can go and it opens and you can cut a ribbon and there's a nice photo op and radiologists love it. You don't have to convince a radiologist to use a PACS. You don't have any of those issues. So everybody loves that. Not that that's got its own problems, but everybody loves that. Try to get an expensive but important back-end, nobody-sees solution through the management board and everybody else with no heat on it. They've tried, for any criticism you can have of what the eHealth office has done, they have tried for years to do this. It's very difficult. So part of the strategic decision was take this burning platform and put in something that we all need and move it forward. So that was what happened. So there are some risks with doing this. One of them is speed. That we are moving quickly with, and we had a discussion, I've had lots of discussions, but we had a discussion this morning about this, with no firm overarching architecture and no Ontario-built business specs. Now, there are a couple things. One, think back. We don't need a lot of Ontario-specific business specs. InfoWay has done a very good job at building a toolkit on this. All the provinces, when they built their RFPs, built them for their own software, built them so that we could share them. So we had 3 RFPs to look for in terms of understanding what the business specs are. We didn't have to create that from scratch. So we used that as a template. We brought in people from around the province, fussed with it, changed it to accommodate some of the issues here, and rolled out with that. We are including key players and long-term business leads in the project structure. So this wasn't shown, I have a steering committee for EMPI that is actually a steering committee, not an advisory committee. That is, I chair and is comprised of the CIOs from those 5 hospitals, so Glenn is on that, Smart Systems for Health, and InfoWay sits as an ex officio. So this is a steering committee. We're just talking about a decision we have to make, procuring an EMPI vendor. And this is a smart group of people who are the leaders really in the field here who are helping us making those decisions. And we're also, as I said, leveraging the work of others. We are also, in terms of the architecture question, specifically put in the specs and are getting advice to make sure that when we put in a provincial EMPI, so a provincial instance, one EMPI from which these 50 to 60 hospitals will relate, we are doing that in such a way that it can flex to other architectural structures as those emerge. So we're not precluding going down to, for those of you who know about the tiering that can happen in all eHealth efforts, but particularly for EMPI, we're not precluding that happening later once the province gets its act together and figures out exactly how that will roll out At a minimum, you'll need that provincial instance. You'll need to buy the software. You need to do that integration into the hospitals. That's all needed, so it doesn't preclude those things. And we're just continually trying to manage this asynchronous alignment with these other strategies. That's a challenge because they're sort of out there, that there's a DI strategy that relates to this, and it's a bit of a dance to figure out who goes first and who goes second. We're sorting that out with fairly good relationships as we go forward. Capacity. What we're really trying, this is a lot of work in a pretty short time. We're trying to leverage the capacity that's out there. It's not significant. You guys are busy in the field, but this is something that when I even started to think about that, I talked to my hospital colleagues, and they all recognized how important this was to their own business efforts, and they're making that capacity. So this isn't all something that's happening either at SSHA, Smart Systems for Health, or Cancer Care Ontario. This is leveraging the capacity such as it exists out in the field, and that's really helping us. One comment we've had is that this is a problem because an EMPI really serves e-health more broadly, so it brings in not just hospitals, but community care access centers, home care services, rehab centers, mental health, all of the other components that are really important when you try to manage someone across a continuum of care. So we recognize that. Now, the first business case, the business use for EMPI really is in the hospitals right now. And when I have talked to the e-health councils for those other areas, and they actually agreed with me. So I was happy to have that because I didn't want to go forward if this wasn't going to work for them. So they're happy generally, probably not to a person, but generally as a sector, happy to move forward using the infrastructure that hospitals do have, which they don't. These other organizations do not have that kind of structure. And building it so that it meets an actual business need, not a theoretical business need that may happen in the future. So we're continuing to do that. It's still a risk, and we're, as good project managers do, we're managing it as a risk, monitoring it, and trying to correct as we go forward if we see problems. So this is the part, when Alan does his presentation, he starts here and works backward. And then I answer this. Well, first I have to actually deliver it on time and on budget, so that's really what's next for me. I expect, and I tell everyone that I expect a lot of mistakes and a lot of problems, and I expect and hope that all of those people in that first diagram with me of the target tell me about those things, and we're able to incorporate that and fix it as we go along. As I said, we're doing course correction constantly. So we have a strong direction, but we do have lots of input, and we keep fixing it as we go ahead. We are remaining mindful, but we're not restricting ourselves to what others are doing. So some of those other efforts that are out there that are a little bit less, that are not as far along in terms of actual implementation, we are being mindful of, but we're not saying we have to do what they do. We're just going, we're fairly bullheaded, and that's, we'll see. We'll see how that works. That, I think, is the only way to get what I need to get done and try to manage the incongruencies as they occur. And we have a continuous feedback loop. So I do these kinds of presentations. I have less formal discussions with my colleagues and their colleagues and others who tell me that they have input into this. So we're trying to continuously get feedback and, as I said, course correct as we go on. So this is a very high-level project plan. The green line represents approximately where we are. We have procured the WTIS system vendor. It's actually not a huge development job. It's more of an implementation issue. So we have a development vendor. They're working. We have an agreement with them. We're in the end stages, I think, of procuring an EMPI vendor. We've gone through the RFP process. We have a preferred vendor that we are just starting to negotiate with. So we're working on that. And then we're just continuing the development, starting the rollout in those first 5 hospitals. Before we roll out in those first 5 hospitals, we'll start talking to the other 50 hospitals probably in November so that they can be ready to go in April. In the meantime, this bottom line is actually important. We are reporting in an interim way from the web-based ad hoc reporting system that we've got set up on current weights. We're starting to report that on the ministry website, and the date keeps changing, but sometime in October. So we'll start getting high-level, non-priorized weights reported there. So what's next? This is really the slide that Alan starts with. He's concerned, as am I, as we all are, with what happens, December 06, I disappear, Alan retires, and I go maybe back to Nova Scotia, I don't know. But you don't want to build something that goes away. And one of the things that we talk about, he and I anyway, and we talk with others about this, an information system is actually a way to keep the thing going. So we both believe that putting this in place will, because it's got public reporting, it's a tool that by then hopefully people will use. The system change that happens will have some hope of sustainability. My own view is all those that political commitment, the speed, the decision cycles, I don't actually think that is sustainable. So that needs to be focused. It is an exception. We need to recognize it as an exception, take best advantage of it while it occurs, and not expect for that to be in place January 07, because there will be some other top issue on the election platform. There may not be, but I'm not assuming there will be this there, because I think that those rules are there for a reason. I'm enough of a centralist and a bureaucrat to understand why they're there and not want them to completely go away. And those will start to impact some of the decisions post-December 06. So I would love to hear your views on what next, but I think I'm done for my time and happy to answer questions.
What a fantastic start to our series. Really excellent presentation. I'm going to give you a chance to ask questions or make comments. We welcome either. And all I ask is that you give us time to get the microphone to you. So I'll look around and see who first.
Dennis Egan, Grand River Hospital. I congratulate, I guess, they got the right guy, Alan Hudson, to do this, and I congratulate what they've accomplished so far. Unfortunately, though, this is, this initiative doesn't operate in a vacuum, and there's all the other surgical services that hospitals provide. And I guess the question is there any efforts underway or about to be underway to monitor that carefully? When you have a scarce resource like anesthesia, which we currently have in terms of manpower, the danger is that, if you need your knee done or your open heart surgery, it's great, but if you need a back or you need gynecological surgery or other types. So I'm just wondering, is there anything in the background? Because we may just squeeze here and then create an even bigger problem somewhere else. So I'd be interested in anything.
No, that is a big issue. It comes up a lot. ISIS is doing a considerable amount of work with us to monitor that and at least acknowledge where it happens and track it. There are a couple of things. One is, my mic on? Yeah. One is, and this is, I'm not going to channel Alan, but I will say what he would say, which is the additional dollars for the cases that were given were incremental dollars. So there should be no cannibalism in theory for those dollars, because you should be doing what you did before plus the additional volumes. Having said that, I said to Dominic earlier, anesthesiology is probably the biggest issue, actually the biggest issue for this whole project to work from a wait times perspective, because it's the biggest constraining factor that we hear from, not just from you, but across the province as a capacity issue. So there are a number of things that he's doing in the broader project to try to get more throughput, to work with the anesthesiologists. They're looking at some new models of care. You looking at me? No. I don't have a strong answer for you. We're tracking. We're worried about it. There's some things in there that I think will help, but it's an ongoing issue.
We have a question from one of the webcast people, and the statement is, the communication to surgeon's office will be web-based. What about the security questions about internet use?
Now you're going to speak out of my, I'm going to maybe look to Glenn here. Because I should have said right at the front, I'm not a technologist or an engineer. So the security issues are largely taken care of within the rules around the privacy and security legislation infrastructure that exists. We'll be using Smart Systems for Health, Secure Exchange, and we'll be using the technologies that are in place to manage that. I think those are generally seen now to be secure and robust. They are at least at the level, if not greater, than those that exist within the financial sector. and have yet to have any problems. But it is, again, it's something we have to go to the privacy commissioner and convince her of that. And so far, so good, but that's something we've got on our list of things to do and to worry about. I don't know if you wanted to add anything.
No. Okay. That was a great answer. I'm not a technology person either.
Okay. There aren't any technology people here, are there?
My question is around, Sarah, is what you might foresee as some of the expected learnings from this project that we could apply to other e-health initiatives or the advancement of the EHR coming from Nova Scotia, where they've actually moved forward with some of those things, and knowing some of the things that we're working on, what do you see some of those key learnings might be for us?
Well, I wouldn't say, even though I was in Nova Scotia, it's not a great it's not a great example because it is so. I mean, Ontario is huge. Nova Scotia and Saskatchewan are 1 million people, so that's smaller than Toronto. I don't know what Waterloo and what the Lynn is, but it's not that physically big, and it's not that big in terms of people. Still lots of issues, though, so I don't want to put my credibility down there. But I think that a couple of things. One is to focus on one thing at a time and have it meet a business need. One of the things I worry about the e-health agenda generally, and Dominic and I have talked about this, I know Dominic too, is that it's sort of an ephemeral need out there. It isn't clearly, the EHR is a generally accepted thing, but there isn't clearly a product or a process that it needs to help do. The wait times information system, I think I said over and over again, meets the wait times need. OLIS is, I think, going to cause some problems because there's no Ontario lab system, right? There's no, the DI strategy I worry about, is Roger Gerard here because I'm going to get in trouble. But I've told him this too. I worry about things like the DI strategy. There's no DI strategy for the province. So it's very difficult to build and manage and maintain focus on a DI information technology strategy. So that's one thing. I hope, I mean, we're still early days, but I hope that that is the learning that we have. I think working very closely with the field from the ground, and I think most of the people that I talk to feel this way. There are a lot of people who don't still feel included, but I think picking a few leaders who are locally and provincially seen to be leaders and working with them very closely as opposed to trying to do everything from the center. I think that's what I was trying to show in that diagram with me in the middle. There's a clear point of accountability, but I talk to everyone and get a lot of input into that. So I think that model is worthwhile. I do think leadership slightly outside of government, but not quite in hospitals, is not a bad thing. I don't think CCO is really not built to do this. This is kind of an exception, but I think there's merit in further exploring the governance structure and the focus on how to actually deliver something like this that has multiple needs. It isn't just for government or just for hospitals or just for CCACs. And I don't think that structure is there yet. I think that's a big issue. Probably others, but those are the main things.
Hi, Sarah.
Hi.
The one question that I really thought of yesterday at an IDC conference that they had suggested in some of their research is that one of the biggest issues in proceeding with information architecture throughout the province is that physicians' offices are not off paper, and some often, if I look at my constituents, don't even have PCs in their offices, let alone internet access. What component of the strategy do you see to address that, or is that up to us with the big stick?
Yeah, no component of this strategy will address that, and that's why I think I can't pull up this. I can't pull up anything, right? You've got this. Okay. I was very happy that the scope. I didn't decide on the scope, but I was very happy that the scope of the weight that we're focusing on is from the point in time that the surgeon and the patient make a decision for treatment and the treatment occurs. That all happens in a hospital, pretty much. There's some places where there are surgeons' offices off-site, but those are somewhat manageable. That all happens within a hospital. That makes this problem, which I know all too well, not relevant for this project. When we look at what to do next and people come to me and say, we should really go out at that first wait, because that's really important to people. How long does it take to see a surgeon in the first place? It's an important wait. We're not doing anything about it. I back away from that, or at least I warn people that that gets into exactly the question that you're talking about, because you're talking about getting information from physicians, not only do they not have systems, but they don't have strong accountability to organizations. They're freelancers. So it's hard to have, even if you had a stick, you're sort of throwing it in the air. So it's a different and really much more complicated question, I think, from a province-wide perspective. Sorry, I don't have a good answer to that.
Other questions or comments? I have one or two. I promised Sarah that I'd at least ask her something. You said in your presentation some days are better than others. How was today?
Today's pretty good. Had a lot of good conversations today and a lot of good learning.
You said one thing along there that really worried me. You said they got their service in this part of the tail, and I was wondering what you were talking about there. Anyway,
okay, I'll bring that one go.
The thing I wanted to ask you about is how do you prevent the system from being gamed? In fact, if the surgeon delays entering the information, which could happen until currently with the hospital, it can look like his or her wait time is a lot better than it really is. How is that going to be addressed? Because that's one of your big change problems as well.
Yeah, and that is an issue. In fact, that's a real issue. We're worried about that, and we have a couple of people looking at the audit function, how we're going to audit this, so that we can at least understand where gaming occurs and try to track it down as it happens. One issue with not getting that first wait is it's easier to game, right? If you don't have that, if you don't have a point in time where the referral was sent and you don't have that clear, you can just, and there are hospitals who I know do this in cancer because we have this problem, they just don't accept they don't make a decision to treat, they don't accept a referral until their wait is short at the other end. That's, not what we want to have happen. So we have an audit process that we're putting into place to monitor it. We also are looking at the transparency and providing that information back locally, not just to the surgeons, but also to the chiefs of surgery and the hospital administrators who would have a better understanding of what's happening as they manage. It's a big question, though, and we are concerned about it.
We have another question from our webcast visitors, and maybe you've addressed it already, but I'll ask the question. What thought has been given to addressing the needs of the surgeon's office in terms of internet or system needs?
Yeah, I mean, it's a little different than what you were talking about, or I can look at it a different way. One of the things that we get asked is how is this going to interface with the surgeons who have systems in their offices? Because this is a different system, and we're not trying to integrate that. And the answer is we're not trying to do that. They will, in fact, have to go into a different system for now, unless, and there are some hospitals who are interested in doing this, we'll build out to this, the province-wide system will build out to the hospital space, and the hospital can then, if they have OR scheduling systems, for example, some of them have built in a prioritization and information request at that point. They can build that interface so either they look like the front end or we look like the front end, but that interface can be built. So there's the opportunity for that, but we're not actually going there. And that's a big issue generally on e-health is what does it look like anything look like at the doctor's office, and is it something that is easy to use or not going back and forth amongst many systems?
I just want to note that evidently we've got visitors from Thunder Bay, Sault Ste. Marie, Cambridge, so I welcome all of those people from across the province. Thank you for attending.
Other questions? Make sure I don't leave anybody out or comments. I want to bring one question. As you know, we recently did a survey through the Hospitals e-Health Council of provincial readiness. A very good response. About 93% of hospitals responded and found through this survey that there's an enormous gap between the capabilities of the institutions and the basic minimum capabilities they need to have in order to participate in some of these provincial initiatives. So that's one issue right there. Right now, it appears that we're investing in provincial initiatives, but not in local information technology, and yet you're impacted by that. And the second part of this I'd like you to comment on is, as you know from our discussion at the Hospitals e-Health Council, I was quite surprised to learn that it's expected that hospitals will pick up 40% of the cost of the system. And I want to understand that more as you go along. So
I didn't have that slide in there for a reason. I kept that out.
Okay. I'd like you to talk about that and react, and I'd even like to have some reaction from people like Glenn who are involved in that.
Okay, so this is with respect to the EMPI, not the wait times information system. This is the EMPI. There's an expectation that the hospitals participating will pick up a share of 40% of the software purchase cost. So we did a calculation. We've done a couple of different runs. It will end up being a share that's reflective of the population within the LHIN structure, the LHIN demographic that hospital serves. It ends up being, at our first instance, it'll end up being about a little bit less than that now that we've got a vendor that we're talking to and the price is coming out a little bit less than what we estimated, less than 1/10 than 1% of the operating costs of the hospital. Why are we doing that? I mean, the province picks up the rest of that. We think, and we've actually had, it was very nice to hear Murray Martin support this at a table I was sitting at, so it's not just me saying this, and it was others saying this, that it is important to have ownership of this, literally and figuratively, at the local level so that change is encouraged to happen. This thing will actually be used. It's not an EMPI that's going to sit up there and not impact the sharing of information locally. It also is a leg. It's a small leg, but it is a pretty important leg. Just like incremental funding has a much bigger impact than the dollar amount relative to what it does. Our view so far, it's borne out that the little bit of funding that is provided has really put all of these 5 hospitals, for example, a seat at the table to decide how this thing is going to roll out, the other 50 hospitals as well. So I'd really like to hear the other hospitals' view, but so far that's really the perspective that we're taking. Glenn, did you want to add?
I mean, I'll just add on to that. We actually had this at our last expert panel where actually we're even talking about the one-time costs, we're talking about the ongoing operating costs. Mm-hmm. And I think it actually is the burning platform for us to not just have to find the additional operating costs to support an EMPI application, but for the pressure to be back on us to say, okay, because this is now going to link us regionally, provincially, what are some of the other benefits we can be getting out of this application? And we need to be forced to be looking at those, not just, me going to my senior team and saying, hey, we're going to cough up, there are $100,000 in operating costs to support this application, but what are the business drivers that can say to us, okay, this actually makes sense now to allow us to link some things between ourselves, St. Mary's, CCAC, Cambridge, and what is the true business opportunity? I think we do need to have some ownership, and we do need to be playing part of the game.
Quick comments on that anybody else would like to?
Anybody? Any CFO?
This is a question sort of directed in a different vein. As I understand it from one of your early slides, the goal is to reduce waiting times. Mm-hmm. But what I see is a project that's going to report waiting times, and then the initiative to reduce them is going to lie at the local level. Mm-hmm. And I wonder about the necessary insights that will come from just knowing the waiting times that will assist in actually reducing the blockages that are inherent in hospital systems and other localized bottlenecks, to identify those places where improvements can be made.
Well, one thing is, you're right. What I talked about is really knowing more about wait times and some tools to help better manage those waits. That's not the whole project. That's why this is it. I can't remember if I said this to you guys or just to the smaller group I was speaking with earlier. The wait times project that Dr. Hudson leads, this is one pillar of it. There are many pillars. This is not, exactly to your point, this is not seen to be the solution to that. There is a significant amount of money, and I should know this, but I don't, in the order of, tens to, I think over $100 million, don't quote me on that, a lot of money being put into buying additional volume. So that is, if there's a problem with the capacity, there should be some relief by putting more supply in the system. It's also not the only thing that's going to help, but there is a strong view that that is important. Other provinces aren't doing that. It's just intuitively that makes sense, and we'll monitor to see how that happens. We also have, Dr. Hudson has a group working on surgical process improvement. So there was a report done that's on the website looking at best practice on managing the OR and getting more throughput, to use business terms, through there, to on the supply side, to get more there. And he is putting into place a number of teams that can go out and help those who request it use that set of tools to get more through. So we are seeing actually in initial information that we get some improvement in those areas. He is also talking to the docs and the anesthesiologists about that capacity issue. So there's a number of things that are happening. I was asked to speak to the information system, but I don't want you to leave the room thinking that it's just about reporting. They're very clear, and really, the Premier wants this stuff reported publicly, but he wants it to go down. So that's really the effort that's being made by the project as a whole.
Just to follow up on that question, I mean, one thing they are doing a nice job of is putting a lot of new money on the table and funding quite well the new procedures. The one mistake you're making, though, in terms of this feedback, and, you know, if I hear the...
There's just one?
Well, the one mistake, though, is that what's happening now is that, I'm the CEO of Grand River, I'm being asked to sign, but the government's also asking our chief of orthopedics to sign, yep, and our chief of anesthesia. And maybe if I understood why you're asking that, I might not think it's an error. But just if I could comment, the reason it's an error is what's happening, and it relates to my earlier question, is those people are now being asked to sign it, and they know that it's very well funded. And so they're sitting there saying, geez, I'm not going to sign it unless you give me X, Y, and Z. I want to do more backs. I want to do more elbows. I want to do more shoulders. And what we're doing is we're putting them in the power position now. And I don't even know what anesthesia is going to ask, but I understand I'm going to have to get them to sign next time. They might want new anesthetic. You know, before they're willing to sign, they're going to want all the any excess dollars that are available. So maybe if I could understand why you're asking them to sign, I wouldn't think it's a mistake.
Well, I don't know if I'm going to convince you of that quite, but I can tell you why the first agreements did not have those signatures on. There have been a couple of agreements state. The first agreements did not have those signatures. And actually a lot of CEOs, one of the reasons we put it on there is a lot of CEOs asked us to do that because the reporting relationships are not as clear as they are for other staff positions with the chiefs of staff and orthopedic surgery, and they don't have a clear, in many hospitals, sense of alignment to the hospitals. And in some cases, so that CEOs asked that. And we also found in that first round, and this is something I could have a whole meeting about what I've learned about how hospitals work in this province. Many docs, many chiefs of staff, and many orthopedic surgeons had no idea that these contracts were signed or any of the obligations and responsibilities that they had. So we had that request from both sides. Understanding, we've also had this comment that this then puts them in a power position to start asking you for additional resources, or we won't sign. But so you don't sign. So what happens if you don't sign? They don't get additional OR time. They don't get additional fees for doing those surgeries. I mean, that's another reason why the scope is so nice, because surgeons can only make money if they get access to ORs, as opposed to departments of medicine and other kinds of physicians that they can do other things. Surgeons can only make money if they do surgeries, and you have control over that. So part of it is, so don't sign it. That doesn't get them to win or you to win. I know that's not sufficient, but it's a bit about the reason about why. And we're actually being asked quite a bit. This is the part of the understanding I'm getting of how hospitals work. We're getting asked by other people and heads of departments to ask that they sign, because there is a real issue in many hospitals. I'm sure Grand River is not one of them, where there's something, to get something from the CEO's office anywhere else could take a very long time and can maybe never happen. And that's a real problem when you're trying to move a system through quickly. So those are the reasons.
We have time for just one more question. We'll take it from the network.
We have another question from a web viewer. Chad Carter asks, what happens to...
I don't know, Chad. Honestly,
well,
you're a funny man.
Chad, Sarah, Chad. What happens to existing or planned EMPI solutions? How will they be integrated into the overall solution?
Well, planned EMPI solutions should not be going forward. All hospitals were directed to not proceed with any procurements for EMPI. There are two EMPIs actually in play, and the procurement and the implementation will allow for a different system potentially to link into the provincial system. And it's not that difficult to do. It is an issue, and it is something I have to talk to. It's Ottawa that has its EMPI well out the door. the Ottawa region, and they've done that in Alberta. They are doing it sort of in BC. So it's not, you can do this. But we did, when the decision was made to go forward with a provincial EMPI, the agreement was that the hospitals would be directed not to pursue their own systems.
I just want to say I have a really neat comic that I lost the actual picture to that shows two people in white coats standing in front of a door marked NASA, and the one saying to the other, you know, this really is rocket science. I think the rocket science here is leadership, and what you're accomplishing in your presentation is evidence of that. Thank you very much.
Thank you very much.
Well, I'd just like to wrap this presentation up. I've been asked to repeat the information about the boot camp, so I guess we've got some people that are interested. So the next boot camp we're scheduling for March or April of 2006. It will be held in Toronto, and we're taking pre-registrations now. And I just want to give my personal thanks to Sarah. That was a wonderful presentation. What a great way to kick off our series. Thank you so much for coming. So, oh, and here's a little present for you. Yeah, thanks a lot.